We have Dr. Jan Dommerholt on the podcast today, and we are so happy to have you, Dr. Jan. Thank you for coming.
Of course.
Thank you for taking your time out of the Fascia Research Congress that we're all here in New Orleans together for, to speak together one-on-one so that I can pick your brain a little bit about some of the things that you're doing in your clinic and in your company, Myopain Seminars, as well as your teaching. We both have a patient population in common that is dear to our heart, and that is Ehlers-Danlos Syndrome, EDS. We talked a little bit prior to this interview about treating hypermobility and how that has a lot of complexity that comes with it in our clinician, the way we provide care. So I guess I'll start us off by asking you, with your knowledge and expertise on dry needling, you brought dry needling to the U.S. You've been a founder of that modality and teacher of that for many years now. So how did treating EDS patients start to change the way that you approach your dry needling in the clinic?
That's an interesting question. Because dry needling, I started doing dry needling way before I became focused on EDS. And I learned kind of the hard way that when you have people who are very hypermobile, and most people with EDS, certainly hypermobile EDS, which is what I see by far the most, I believe that they create contractures over their joints to keep their joints together, to keep their limbs together. And when you do a lot of dry needling in those contractures, you actually make their hypermobility much worse because they literally lose the one thing they were holding on for dear life, literally. They lose that, and joints will actually fall out of the sockets. And so I've learned to really modify that quite a lot, and not just like, oh, there's a contraction, I need to stick a needle in it, but actually like, all right, what makes sense? Like what is the restriction? So I use the dry needling in the EDS population mostly to control their pain, so that next they can start moving much better and actually moving more controlled mostly by strengthening and by doing other kind of things that would help them in their lives and with less pain.
Great. I love that you're mentioning this because I feel that professionals certified in dry needling who practice it would go right after the trigger points and go towards that tissue that is stuck or fibrosed. And you're exactly right. I agree with you that if we do that in a patient with EDS and hypermobility, we are compromising their joint stability in a way.
Absolutely.
Yeah, we're taking away.
There's no question, and I have to admit that when I first did this, even in one patient I recall vividly, she had pretty severe hypermobility and a lot of pain. I treated both her shoulders the exact same way. Her dominant side, her right side, was just about as good as it could get, and her left side got worse. And although we did the same thing, so that shows you that you really have to be very careful. How much you do, you're better off cautioning on that, being a little more cautious to it. Just like, well, let's try a little bit, see how you respond, see how you can handle this. Can you integrate this in what you need to do? That patient I never forgot. That was early in my EDS life, so to speak, as a professional. She was very happy. She said, you gave me my dominant arm back. It's fine. My arms didn't work before, so now one at least works, and it's my dominant side. She was quite happy, but I never forgot that patient because I realized we need to be much more precise and much more careful and much more graded in how we introduce this modality of dry needling. The dry needling is just a step up towards, okay, now you need to get stronger. I mean, we know for sure, that's old research by Peter Haring in the Netherlands. Fascia is responsible for up to 40% of muscle strength. So I tell my EDS patients, your fascia is not really doing that. So you're probably 30% in the hole as far as muscle strength is concerned.
Yes.
So we need to get you to get much stronger. That has to be a part of your daily life you need to strengthen. But because you're in so much pain, you're not going to do that. I vividly know that all the books on EDS from the UK always said, like, don't worry about the pain. The pain is the last thing that will go away. Now, I have never met a patient who can just ignore their widespread body pain. They say, oh yeah, I'm just going to ignore it. I'm going to exercise. So you need to have something, whether it's dry needling or something else. It doesn't have to be dry needling. You need to have something to make the patient feel much better about themselves, not in as much pain, so they can actually do the things they really need to do, and that is exercise.
Absolutely. Removing the barrier to exercise and movement so that they can incorporate that daily. And of course, we're talking about this is over a long period of time where the patient might be going through flare-ups and setbacks, especially with our EDS people. So I would like to touch back on how you use dry needling specifically for pain control. What kind of methods do you find work in EDS patients?
That's actually probably not different in EDS with other patients. Myofascial pain, if you want to call it that. I prefer not to call it myofascial pain syndrome because I'm not convinced that it really is a syndrome. People develop trigger points with any pain problem you can think of, whether it's headaches, whether it's more systemic like EDS, whether it's low back pain, it doesn't really matter. Once people have trigger points are really contractures in the body. In the myofascial, they call it taut bands, but I really prefer the term contracture because that's what it is. These muscles are so partially so contractured, I should say if that's a word, that they have a lack of blood flow. When there's a lack of blood flow in that part of the muscle, your nervous system will deposit lots of chemicals, calcitonin gene-related peptide, substance P, and many, many others that cause pain. So now you have all these nociceptors get activated, and you can say whatever you want. People are not going to exercise when they're in pain. Using dry needling or fascial techniques, and in this conference certainly there's another shortage of different approaches that people have developed. And it's all good, it's all lovely. I find dry needling superior to most of them because my little fingers are always much bigger than that little needle. The needle has so much more specificity. I can really get to that point. I can get rid of that contracture in seconds. I can treat painful scars in seconds with needles and then do manual stuff with it to get rid of the contraction, let blood flow go in, the hypoxia, the lack of oxygen is going to disappear, the chemicals will disappear, and the patient is like, I can move, thank you so much.
Yes, I love how you've really blended in the tool of a needle into like that specific tissue reset. Because we have to have blood flow for healing. We have to re-oxygenate tissue that is lacking it.
Absolutely.
And your point of, I think that is a powerful message to all manual therapists. We love using our hands, but our joints are also going to take the wear and tear over time when we're using hands only.
There's that, but there's also, if I want to get rid of a structure, it's not a structure, a physiological phenomenon that involves a few millimeters in the tissue. If I want to do that with my fingers, it's like squishing a ping pong ball with a pillow. My finger being the equivalent of the pillow. You probably will impact that ping pong ball at some point.
Yeah.
But it's much easier to use a hammer and just smack it.
Yeah.
And the needle is more like the hammer. You can be really specific. And I don't really think it's not a manual technique. The American Physical Therapy Association has grouped dry needling within the manual therapy category. It is, to me, an instrument-assisted manual therapy, just like Graston or any of the other instrument-assisted tools. It just happens to be invasive, not minimally invasive. That's what they say in Spain. They call it minimally invasive. It's like, that's kind of like being minimally pregnant. The needle goes inside, it is invasive. Right. There's no such thing as minimally invasive. Yeah, it's a minimally thin little needle. I get that part. I know why they're saying it. It is an invasive procedure, no question. And you can do significant damage if you don't know what you do.
Yes.
Pneumothorax, epidural hematomas when you needle too close to the spine. Those are very serious plus possible complications. The good news is they're always preventable. There is no reason to put your patient at any risk like that. But then as an instrument-assisted manual therapy, that needle is an extension of my fingers. So part of the training, if you want to get good at dry needling, you have to develop that proprioceptive skill just like the old-fashioned carpenter with their hammer. That hammer became a part of their hand. Now they use pneumatics and they have no clue what they're doing anymore other than lovely. But the old-fashioned carpenter would never hit a nail when they would use the hammer, because that hammer became part of their body composition almost. Dry needling is very similar. So that nociceptive skill of having, a proprioceptive skill, having that needle become part of your finger so you can actually palpate with it.
Yes.
So you can know what you're doing so that you can really address your therapy, especially for an EDS population. I think it's critical.
Oh, absolutely. I can feel, as you're speaking about the proprioceptive input of the needle, I can feel when I'm in crunchy or sticky tissue. And as you're discerning that, it's a great tool to complement manual therapists.
Absolutely. Well, it is manual therapy. It's not even complementing.
Yeah,
It's part of manual therapy. And what you're saying is so true. I mean, in this conference, there's a lot of emphasis. Even before this interview, I attended a session on scar tissue. And people talk a lot about the deep fascia layers and the lack of hyaluron. But with a needle, when you have that crunchy feeling, like you're almost going like through sandpaper, like your patients can hear it and feel it.
Yeah.
It's like, and people are like, what was that? Like, well, it's a sign that your connective tissues, your fascial layers are too sticky.
Yes.
They're not moving, you're not gliding, so you can't function really well. And the interesting thing is, even in your EDS patients, as has been shown by the Carlos Stecco and Antonio Stecco and others have done research on that, even in these very hypermobile people, they have regions where they're hypomobile, where their fascial layers are completely stuck.
Yes.
The problem with that is that healthcare providers, physical therapists, chiropractors, manual kind of other people, body workers, they often look at that. Let's say if it's in the spine, is it, oh my gosh, you're so stiff here, let me mobilize that.
Yeah.
It's like, no, leave it alone. That is the one part of the body that's actually functional.
Yes.
The rest is the problem. The hypermobile part is the problem. The hypomobile part is probably normal. So leave it alone. Help that patient understand. Stop stretching for the rest of your body.
Yes.
Because you are maintaining that hypermobility. But when someone with hypermobile EDS stretches, they're not stretching their muscles. They're stretching their capsule. They're stretching their ligaments. They're creating more hypermobility. So it's an interesting phenomenon that even though you're super flexible, you can still have areas of stiffness. That then you need to fine tune, like, okay, how does that interfere with actually moving, but being able to strengthen, being able to do the things pain-free? Or is that something we should leave alone? It's like, no, that is actually perfect.
Oh, I love this perspective. It really reminds me of my training with Dr. Stanley Paris. And through St. Augustine, it was very critical that we determine where is the hypomobility and where is the hypermobility. Compared to my manual therapy training in PT school, just the standardized training, I'm sure that I mobilized some hypomobile tissue in patients as a new grad, not understanding that right next door was a hypermobility that we were affecting in a negative way. And so I think it's so critical for PTs to understand what's the neighborhood they're dealing with and where there is hypermobility and EDS. We have to take care and, like you said, stabilize. We need stabilization and precision and specificity when we're treating the hypo parts.
No question. No question.
I love that. So let's move forward to some of the movement base in your clinic. So I know you have a collective of PTs who have trained under you to do needling combined with movement science. What kinds of movements do you feel like help with EDS once they're ready for it?
I am a strong believer in external focus exercise, and which is not the norm in physical therapy. I just actually was on the doctoral committee of a physical therapist who did a doctorate, and her dissertation was on that topic. She found research that between 70 and 98% of physical therapists do never ever use an external focus approach. So what do I mean by that? Many years ago, I had a 12-year-old girl with EDS. She kept dislocating her hips, and I didn't really have anything in my clinic at that time to help her with exercise. Her mom found this phenomenal clinic. She said, "What do you think of this?" It was run by an athletic trainer, so I called him up, and she said, "It's probably best if you go over, because it's hard to explain what we do." Now, he did not have a scientific focus, but he was very intuitive. As a kid on the autistic spectrum, when he graduated, he said, "I want to create something that kids like me can have a chance to catch a ball."
Awesome.
So it's really from his innate personal experience that he developed his clinic. When I walked in, the first thing I saw was a 30-foot trampoline. And I'm like, wow, is this a PT clinic? I sent the kid there. He had never heard of Ehlers-Danlos Syndrome, so I had to explain the do's and don'ts. I saw the kid 6 weeks later. 6 weeks later, she was happy, she was motivated, she was getting strong, she could participate in school activities. It's like, what did you do? I sent another kid, same experience. Then I said, you and I need to meet. And we actually set up a partnership that I moved part of my clinic to his clinic. So I opened up another facility inside of his clinic. And that's when I really learned what is this all about. Harry from Picard's, Dr. Harry from Picard's, the head of the Crafter program that we teach course, the Craniofacial Therapy Academy. I showed it to him. He said, this reminds me of Gabrielle Wolf. I was at a conference once with her. You should look her up. Well, Gabrielle Wolf is a German researcher in Las Vegas. She wrote a book. She wrote many articles. I read every single one. I contacted her. I went to her workshops. And she and Luthwaite and other authors have developed the optimal motor learning theory of movement. And what that means is that they've shown that if you focus on the body while you exercise, the body will automatically limit itself in its possibilities. So a simple example, if I would put you on a wobbly board and I give you a box, an open box with a ping pong ball in it, and I say, can you hold your hand still so the ball doesn't move? Chances are you can't do it.
Yeah.
However, when I say, can you hold the box still? You do perfectly fine. So when we in physical therapy tell patients, oh, you need to contract your core muscles while you're doing something, we're not really doing that other thing that we need to do, which is the functional activity.
Right.
So rather than focusing on limit your range of motion, EDS, functioning mid-range of motion, yes, I know they need to function in mid-range of motion, but you relay that to a patient, they're not functioning at all. They're so focused on what does that mean, and they really forget to do that. So if I want to train someone, let's say upper shoulder strengthening, I may put them on a Bosu ball if they're stable enough in their ankles. If not, go down a level, maybe a flexible pad, some foam pad. Put them close enough to the topic, whether that's blaze pots or some other light that they can knock out, or a balloon they can play with. But put them so close that they cannot fully extend their arms, so they're always doing exercise in mid-range of motion.
Nice.
So you're programming their brain, their body, to contract their stomach muscles, because if not, they're going to fall off the Bosu ball.
Right.
While they're doing an activity, give them some weights in their hands that don't look like weights, so they don't associate, oh, my arm weights, I can't do that, I'm going to hurt. Use a ball that's weighted. They can do things with their arms, strengthening all their muscles while they're incorporating their whole body awareness, even without knowing it.
Love that.
They need to wake up the next morning. I can't believe I used muscles I didn't even know I still had.
Yes.
And I think that is what we do in our clinic very strongly with an external focus. We do some internal focus. If you really need to strengthen muscles, you need to use an internal focus. That research has shown it works better. But our clinic looks like a playground. We do virtual reality. We do all kinds of things with lights and knocking out things and slap boards. And I mean, it's all about how can we trick your brain to not restrict you in what you do.
Yeah.
Virtual reality is a perfect example. Even in the non-EDS patients, I'm sure you have had patients with back pain. And you said, like, well, certainly if they've seen another therapist or another health provider, said, can you squat? And so many times people say, oh no, my SI joint or my hamstrings, I can't do that. You know, when you take that patient in a virtual reality and you give them a program where they punch little things out of the air, but every now and then sometimes comes at them and they have to squat.
Yes.
Every single one will squat.
Yeah.
Although
totally.
they just told you that they can't. So in a different virtual world, we can do things, which shows to me that in our real world, our brain is restricting our movement. So you need to find a way, whether it's EDS or anything else, you need to find a way that patients can experience movement.
Yeah.
So I'm not a big fan of cognitive behavioral therapy and pain management in physical therapy. I think it needs to be behavioral cognitive therapy. Let people experience that they can move, change their behavior, and then the cognition is like, I can't believe I do that.
Yeah.
I haven't exercised like this in weeks. I'm sweating. I haven't sweated in years.
Yes.
Once people have that realization, then everything will fall into place. So rather than saying, what are you afraid of? Oh, let's work on that today. So that's an internal focus direction.
Yes.
Immediately you get this like, I can't do that. I'm going to be in so much pain. If you just play with people, to exergaming, external focus, well, the therapist has to be very aware. What do we need to accomplish?
Right.
So create an environment where that patient can be successful rather than experience another episode of failure. When people become successful, the behavior, change the behavior, cognition will follow, then it becomes therapeutic.
I love that approach. It's very empowering to the patient.
It is.
We can see the light bulb go off in a patient's mind and behavior
Correct.
when
Correct.
it happens.
Correct.
And they're like, I did that.
Yes.
And I love that you're taking that overthinking component out of it.
Yeah.
I feel that my EDS patients will tend to overthink their body movements. Like you said, do not extend to the end range, go to mid range. And you're right, it takes a lot of cognitive processing to move about the world and think, oh, don't lock my knees, don't do this, don't do that. It's a lot of don'ts for them in typical therapy.
And it's partly iatrogenic, I think, that they're so overthinking things because, it takes 10, 12 years before the average EDS patient even gets a diagnosis.
Yes.
So they've been told all kinds of nonsense. Oh, it's growing pains. Don't worry about it. Children don't get headaches. Or all the typical things that they're being told. Growing pains, like that is
Right.
probably the most common thing EDS patients are told.
Yep.
I do not understand why we believe that all of a sudden the body forgets how to grow. That
That
concept
it has
of
to be painful.
the concept of growing pains makes
Yeah.
no sense to me at all. Like, why would the body forget how to grow? Why is it typically that girls, especially after their first period, within weeks, their joints become painful?
Yep.
And right before that, they're not. That has nothing to do with growing pains. That is a physiological changes in the body that are so dramatic that now their connective tissues are problematic. They are growing. Clearly, then is more load on their tissue, so that's part of maybe growing. Maybe that you could say maybe that goes with growing pains, but the concept of growing pains makes no sense.
Yeah.
Many of these kids are really hypermobile, and they need to start exercising very quickly.
Yes.
And they don't like the message. I have been beaten up by 14-year-old girls standing in front of me and beating me, I hate you, I hate you, I hate you. I'm like, are you almost done? And we can talk about it.
That's intense.
I get it. It's intense because no one wants to hear I am different than others.
Right.
And so I don't even call it a disorder when I meet with patients. It's not. It's just who you are.
Right.
You're a unique individual. Don't give up your dreams. A few months ago, I had a 20-year-old college student. She was just diagnosed, and she was very depressed because she wanted to be a forester. Mm-hmm. She wanted to work for the National Health Park Service and be out in the woods and do stuff that the rangers do. And she said, well, I could never do that again. It's like, why not?
Right.
So why would you think that you can't do that? So if you want to do that, get to work. We can help you accomplish that goal. We can make you strong enough. You can make yourself strong enough. Just be committed. You can do anything you want.
Absolutely.
Maybe not trampoline jumping, maybe not bungee jumping, all these high velocity,
Right.
explosive exercises. Frankly, no one should be in roller coasters and no one should be doing these things because they're probably not healthy for you.
We know too much about OA joints.
Absolutely.
On
So
roller coasters.
cervical instability in EDS patients, they should never be in these high velocity
No.
activities, never. And if they do, and I've had patients who don't believe me or like, oh, I can do it, and they're miserable for months after that sometimes. Yep.
So I love that you are, with your patients, providing a pathway forward to those achievable goals.
Yep.
And with pain management via dry needling. Let's talk about E-stim for a second. I don't want to forget that one.
Sure, but I want to make one more comment because no one really needs dry needling. I want to make that very clear. So dry needling is not for everyone. And dry needling is just, in this context, is just a tool of one of the available tools we have to move people forward from I can't do anything because I'm so miserable and painful. I feel so sorry for myself. Not everyone is in that. I'm making a little black and white here, but it's just one tool.
Yeah.
And it's not something you need to do forever, but many of our EDS patients do get dry needling as part of their lifetime achievements.
Yes.
So what about E-stim?
So E-stim, okay, thank you for clarifying that. It's so true because we do know PTs in the profession who the saying is, needle everything that walks in the door. And we know that that's not clinically sound because not everybody needs a needle in them to heal. So what about the use of E-stim with dry needling? I know that my training was with Kineticor, a different company, and you've mentioned how many different training companies are there now in the U.S. for dry needling?
In March, I found 57 in addition to ours.
That is a lot, especially because they all have their independent style, right?
I doubt that. I think there's a lot of copycats in the market, to be honest. So whether people have given it enough thought to really say, oh, they have their own spin on it, I kind of doubt that. But E-stim is becoming a very popular thing in many courses. Physical therapists now call us, our office, email me, do you do E-stim in your courses, in your dry needling courses? And the answer is, do you know how to use a TENS unit? Do you know how to use a neuromuscular stim unit? Then you probably know everything you need to know. Because really the only thing that's different at this point is this form of the electrode. So rather than stick slapping an electrode on the skin, you go through the skin, so you don't have to worry about skin resistance. That's one big difference.
Right.
But if you look at the research, and we do have an online course in E-stim and dry needling, but we stopped that course twice because, why are we doing this? There is no research on this whatsoever.
Right.
Just because it's so popular doesn't mean that that's necessarily such a wonderful thing. We stopped it twice. We did a systematic review. We found 6 papers on dry needling and E-stim. That's it. We did another review looking at why does it work. That became a scoping review because there were only 4 papers on mechanism of dry needling and E-stim. Now, most recently, 2 months ago, I co-authored a paper where we actually looked at ultrasound of the tissues, dry needling versus dry needling with E-stim. And interestingly, both had parts where it was superior.
Okay.
So there were definitely parts, range of motion improves more with E-stim and dry needling than dry needling itself in this patient population. So there were definitely now, that's one of the first papers that I am aware of even, that showed that dry needling with E-stim had some pretty unique changes. Is that enough to then say, oh, we need to do all this? Even last week on social media, I saw a little thing, a blurb from some other company. Oh, now we know how to treat sciatica with E-stim and dry needling. It was a pilot study. So pilot study are not meant to draw conclusions from. Pilot study are designed by definition to explore, is there some possible truth to what we come up with this intervention or this idea?
Right.
If that seems to be the case, I've done many pilot studies, then you say, okay, that looked good. Let's not do a really big study and see, does it really pan out?
Yeah.
Well, and then you do a few of these big studies, then you can possibly say, all right, there's enough evidence to actually move forward and do this.
We need more. Yeah.
We did this with recovery. Like in athletics, sports, recovery is a really big topic right now.
Yes.
So we thought, like, can dry needling, and other people have done that too. Sue Falzone, who's actually at this conference, she has published a paper on recovery with ice hockey players. So we collaborate, we talk to each other. We did a study of recovery on 10 subjects, or 14 subjects. That was done in Iran. I work a lot with Iranian physical therapists. I've been there several times. Not on my top list right now to go to, but the world has changed a lot.
Let's keep you here for now.
Yeah, that's probably better. I agree. My wife would agree with you. So we did a small study. We did some objective tests. We created fatigue in the quadriceps muscle, needled it, and see how quickly do people recover. And it was very promising. So now we're doing a big study on taekwondo players, professional people who do taekwondo, and see, does the dry needling in a high-level athlete, does it make a difference?
Cool.
There are not enough studies yet to say, like, oh, you need to do dry needling for recovery.
Right.
I don't mind playing with it. I don't mind saying, that may help you. Let's try it.
Figuring it out.
I'm not really sure.
Yeah.
What I object to from quite a few needling companies, then they make it sound like, oh, this, if you don't do that, you're a loser.
Right.
And like, no, there is a place for dry needling in E-stem, but let's not jump to too many conclusions. I honestly believe that a lot of physical therapists are interested in E-stem because our reimbursement is not exactly great lately. If you do E-stem, you can see 3 patients at the same time. So I think E-stem becomes a tool for economic recovery.
Let's mention that because we talked about how our clinic model is a one-on-one basis. Yep. And for that patient, especially when we're talking about complex diagnoses like EDS, to really be seen through the whole treatment plan requires a lot of the one-on-one time.
Yep.
And so whenever there is a modality like E-stem that's covering the bases and allowing you to have 3 patients across, 3 tables, and they're all receiving billable treatment, this is a sad scenario for quality of care.
Yeah. Mm-hmm. I think that our profession is going through a lot of changes. Mm-hmm. I think the interest of private equity firms in healthcare is not necessarily a good development in this respect. You can go to the APTA CSM meeting and you see very large companies recruiting new graduates. They give them a $15,000, $20,000 sign-on bonus, and 2 years later, half those people leave the field.
Yeah. Burnout.
Because there's burnout, there's like, this is not what I signed up for, and it doesn't have to be. With the shortage of physical therapy, and the APTA predicts that shortage will only increase, new graduates need to be taught in school, you have all the cards in your hands. Yes, right. You do have a lot of debt because physical therapy school is ridiculously expensive. I totally understand the temptation to like, $20,000, that's such a big chunk of my debt. Right. I get it. But you don't get any mentoring. You don't get anything about any private equity firm. The objective is build up the company, sell in 5 years with a higher profit margin.
Productivity.
That is the model. It's a productivity model. So from my point of view, it's about 16 to 20% of clinics now are private equity owned. I am not convinced that I'm quite sure that is not the way to do it. And it facilitates this. We need to do E-stem in our clinics so we can increase productivity.
Right.
Rather than really connect one-on-one with an individual and say, like, tell me your story.
Yes.
What's going on in your life? How can I help with it? How can I, as a clinician, connect the dots in your life? Okay, you have gastrointestinal issues. You're also hypermobile. How about your skin sensitivity? Are you allergic to soaps or to detergents? Mm-hmm. Okay, maybe you have mast cell activation disorder. Or you get dizzy when you get up. Okay, you have dysautonomia. What are the modules you subscribe to as an EDS patient? Let's figure it out and let's work together.
Yes.
I now use an AI recorder with my patients. So I said, like, I really want to listen to you. But if I have to sit behind that computer, promise, I have half of what you're telling me, I'm going to not register.
Right.
I'm going to record our conversation so that later my AI synthesizer will create a beautiful report. I'm going to critically review it to make sure there's no nonsense in it. But I want to connect to you.
Wonderful.
So the most important thing is not dry needling. It's not external focus exercises. That therapeutic alliance you set up, you develop with your patient. Absolutely. Against the background of knowledge, skill. Young physical therapists are not that interested in attending courses because they need to have their work-life balance. And granted, when I was that age, that was not much of a work-life balance. It was work, 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 work,
Yeah.
work. Take courses, take more courses. And you mentioned Stanley Paris. I remember his 10-day S1 course. Today, you couldn't get away with that.
No.
I've had a physical therapist in my office who said, oh, I can't take courses. I've worked all week. My work-life balance. He said, but everyone else in the course works all week. How can you get ahead? How can you instill in patients the sense that you actually know something, that you can help them, that you can be that little enzyme that helps them move forward? Physical therapists are not healers. We're catalysts. We're enzymes.
Yes.
So as an enzyme, I still need to know what my function is.
Yes, working together, the alliance that you spoke about is very beautiful. And I think it's a really important piece of the training in an early PT's career so that you're not there to just pay off your loans and see 18 patients a day, but you really are sinking into those softer skills. Dr. Wang and I talked about that this morning as well, how important it is to be able to establish the trust with the patient and say, we're going to do this together.
I think that is the key of being a healthcare provider.
Yeah, absolutely. And it's the fun part.
It is the fun part. Connecting to people is why many of us go into this field.
Yes.
And I think it kind of gets a little bit lost in the translation sometimes because all these other things play a role. And yes, we need to get paid more. Physical therapist salaries have stagnated. And right now, if inflation would have accounted for, starting salaries of PT should be around $150,000.
Yeah.
Compared to many other professions and what it used to be.
Yep.
The education cost went up, so physical therapy students, new graduates, have a lot of debt, many of them do. And they're torn, like, how can I make this all work for myself? And I think with good mentorship, that's what they should be looking for.
Absolutely.
And still get paid decently. Can I afford to give someone a $20,000 sign-on bonus in my little practice? Probably not. I don't do it because that's not really feasible.
And you might lose that PT within a year.
Of course.
Big loss for the company.
Yeah.
Yeah.
So I think it's a very multifaceted problem, but we cannot forget that therapeutic alliance and having the skills to sit down with someone and really trying to connect, like, I'm here for you. Tell me your story. Also being able to ask questions that they probably didn't want to tell you about because they were PT. Like talking about stomach pain. Like most PTs patients do not report, I have a lot of pain in my stomach. Right. You're a PT, you do muscles and bones, you do not do stomachs.
Right.
And it's such an essential part of EDS and so many other things.
Oh my goodness, yes. That makes me think of when patients present, and I have a GI screen, especially with my EDS, but when they come into the clinic and they've already separated themselves out because that's how they've been treated by the medical system. So you're right, they're not bringing their GI problems or their mental health problems or other things that we need to screen for.
Absolutely.
So having the time to see them as a whole person is a beautiful part of our process.
Yeah.
Thank you so much, Dr. Jan. I really enjoyed this conversation. I'm very grateful and appreciative to you for everything you've done for our profession in this country and around the world in advancing our education and continuing to ask the questions so that we can discover more about, what is really effective and how can we truly help others. Thank you.
It's a pleasure. Thank you.